wasn't necessarily anything that we did wrong. I mean, maybe we could have educated more frequently. I mean, we did educate. I have it documented. I promise I saw it. But this particular individual thought that, you know, leaving that dressing on for as long as possible was the best way to prevent an infection, including through shower use. So sometimes it's not necessarily anything that we can have any control over, but sometimes it is. So the wound classification comes up because, and the PATOS, present at time of surgery. So for February, I was able to, and keep in mind, when I say I've identified them in that month, that's the month the surveillance, the date of event occurred. That's the date when the first sign of infection. That's not the procedure date. I do have rates with procedure dates. I do track that down as well. But so in February, there were 2 colon cases identified. One started out as an exploratory lab, one was a sigmoid resection. And both of them, thank goodness, were documented at surgery. The infection was present at time of surgery. So what that means is, as I enter this information into NHSN, which I'm legally obligated to do, federally recognized surveillance system, I can click, yes, that surgery was present. Yeah, the surgery was present when you guys did it. No, the infection was present at time of surgery. So what that does is CMS goes, oh, okay, we're not going to take away your funding for that one because it's not necessarily your fault. You know, we'll risk adjust in your favor for that. So of the 3 that I identified in February, 2 of them will not count against us, which is fabulous. I'm still counting them towards our surgical site infection rates. Monetarily, they're not going to count against us. That's specifically what I mean by that. The second one was a breast surgery. It was a total mastectomy with implants and grafts, and the grafts had to come out. They were infected. But again, that was a 30-day surveillance. I do 30 to 90-day surveillance. This is based on the operative procedure and what NHSN defines as being the time frame. And again, the closer to surgery it happens, the more likely it happened during surgery. So I have a couple of cases for January that came up that I noticed with the hair clippings. The hair clipping was done in the OR suite. So we are working on that to try to get that done prior to entering the OR. Because no matter how you cut it, no matter how pretty you do your hair or what you do to maintain it, it's filthy. It's dead skin cells. That's basically what it is. So if we're clipping in our OR suite, then we have, you know, it's like Edward Scissorhands with the clipping of the hedges. It just poof, poof, poof all over the place. And then it has the opportunity to enter back into that site and cause an infection because we don't know what kind of bacteria is hanging onto that. I mean, we have mites that live in our eyelashes and our hairs. It's bound to happen, cause an infection.
Thank you for that.
Yeah.
Yeah, anytime, anytime. Sure. What else do you guys want to know?
Thank you for that.
I love this stuff. So let's see, what else should I cover? Is there any questions you guys have for me? Are you guys interested in knowing, like, do you want me to try to bring back to you guys surgical site infection rates or like real time as quick as I can? Okay. Okay, great. Absolutely.
You know, we do a lot of vascular. We'll have gangrenous feet.
Yeah.
And we're cutting off their leg.
Yeah.
So that's got to be colonized all over their body.
So yes
but
and
the incision,
no.
you know, it's kind of a gray area.
Yeah, absolutely. Okay, this is an awesome question. So whenever you're thinking about wound classification, think about the wound itself, right? So my foot might be rotten to the core, but you're cutting up here, right? So, but up here is not rotten to the core, right? So it's always where you're cutting. It's wherever the incision is happening, because that's something else we're working on. We should have pre-op baths, which is completely out of your control. You guys, you don't have the time to bathe all of your patients personally. So I'm working on that. If they're an inpatient, I'm covering it in orientation now. I'm hitting on the floors to talk about it. We're trying to make sure that they have a pre-op bath for decolonization of the skin, not decolonization, for a scrub of the skin. And then in our outpatient settings, we are trying to get all of the outpatient centers to have individual bottles of like the brand name that's coming to mind is Dynahex, but it's a CHG solution that you do at least the night before and the morning of. It's supposed to be 3 days, but if I can get the night before and the morning of, it'll be a wonderful start. So we're trying to do that that's an actual decolonizer. But then your skin prep will take care of anything that's on there, decolonization-wise.
So that should be a clean?
Theoretically, yes.
And how about if he has MRSA? I mean, is that?
Colonized? Or like active infection?
Anywhere.
So, there was another case with MRSA. So, two different things. So if it's colonized, it's basically like a squatter in an empty building. It's not doing anybody any harm, it's just annoying that it's there, right? But if it's an active infection, then they're at a much, much, much higher risk, in which case their preoperative antibiotics should reflect that. So they should have a vanc and a aminoglycoside for their pre-ops to reduce that risk, but it depends.
Does
So
that
like,
change our wound class?
not necessarily, it depends on where you're cutting, where the infection is.
Again, I'm going with the amputation.
Sure, so
MRSA in the wound, in the foot, but we're cutting their leg off below the knee, above the knee.
It's clean. Yep. It's wherever the knife's going in. Yep. So I literally have this really beautiful oozy goozy green coming out of my heel, but as long as you're doing it, right below my knee, it's a clean cast. Yep.
Along the same lines, probably the same answer, but I just want to double check.
Sure.
So you have a woman up in stirrups, you're going to do laparoscopic belly surgery,
Uh-huh.
and she loses her bowels on the table.
Sure.
That does not change, that's still a,
Right.
depending on, if it starts as a clean contaminated, it's still clean contaminated.
Yeah, because as long as
Okay.
it's, wherever you're
Okay.
working towards.
Okay.
Yeah, it's just unfortunate for you that happens. Yeah. It's just a bummer.
Right.
Yes, absolutely. Yes. Speaking of MRSAs, so everybody in here is directly, you're in the OR suite, not PACU area? Okay. Anybody that's colonized with MRSA, just as an FYI, that has the opportunity to go anywhere. MRSA is very similar in the regards that it's an opportunistic infection. So a lot like HIV, right? It attacks where you're weak. It's not exactly like HIV, they're totally different, but it's opportunistic. So I can be colonized with MRSA, and that MRSA will wait until I have a weakness somewhere in my body and attack that space. So if I'm going into surgery, that has the opportunity for that MRSA to travel down to wherever I'm having surgery. The other aspect of that I want to make sure that we're all aware of is if they're colonized, all they have to do is pick their nose and touch their wound and they'll have a MRSA infection.
Which happened.
It did happen.
Potentially.
Yes, yes. We had somebody colonized, and then 2 weeks out, after I think 2 wound dressing changes, oh look, there's MRSA, and it was a superficial infection. Superficial on the skin. A deep infection goes to the site, it's below the subcutaneous tissue. It's within the fascia and muscle layers. So yeah, that's something we have to be aware of that happens. Not necessarily anything we can stop, but something we can educate for. Just so you know, hey, you're colonized with MRSA. That travels by contact. So as soon as you pick your nose, and don't even think they're not doing it, we're human, we all do it. But as soon as they do that, make sure that they're washing their hands before they touch their wounds. And I keep leaning back because it was a Lenny that happened to.
I thought it was
Oh no, that's right, that was the carpal tunnel release. Yeah. Sorry, I do this because that's like the test for if you have carpal tunnel syndrome. Yeah, carpal
So
tunnel.
that doesn't change, if it's colonized or a wound, it doesn't change our procedure unless we're working correctly there.
That's right. Yep. Yep. Or if you see an abscess. One of the catches from February was amazing. It was very, very awesome because they cut in, they were doing a colon case, the colon looked fine, but there were pockets of abscess in the abdominal cavity. So that might not have been necessarily directly at the site of incision, but when that person came back with an intra-abdominal abscess on a CT scan that we then had to put in a drain for, we could count that as patos because the abscesses were there, present at time of surgery. It's wherever the action is happening, right? So I might have a cat scratch fever, right? I might have a cut from my cat that looks crazy infected. But then I actually go in and let's put it on my leg. So I have a cut from my cat and then I go in for a total knee. But then I come back within, 28 days. And I have to have that whole knee revised because it's a septic joint now. It's no longer functioning. As long as that infection is deep in the organ space, I cannot attribute it to the cut that was on my leg because it's not superficial. Does that make sense? So wherever the infection is, if they come back with a surgical site infection, it's got to be at the same depth. Make sense? Okay. I feel like I'm confusing some people. Please shout out with any questions at all.
But why is that? If it seems like it's something that was obviously carried over from that scratch, why?
So if I have, so the theory is, if I have a cut superficially on my knee, and then I have a total knee revision, I should have had that cut covered, both with my skin prep and my antibiotics on board to prevent anything from transferring deeper. That's the theory behind it. Yep.
Which is why but we don't even take any chances with that type of thing. If a
Right.
patient has a scratch or something when they're getting a photo, we're like, yep, we'll wait till that's healed. Because we're not
Perfect.
even gonna mess around with that.
That's even better. That's even better. That's great. So I got to meet, I'm gonna say it wrong. Rader?
Chris Rader.
Yes, I got to meet him the other day, and he gave me some amazing information that I never had access to before. I'm so excited about this. I can give you guys SSI rates in virtual real time. Virtual. Because I have to wait till the end of the month to get all the data. But, so just so you guys know, because we thought, oh my gosh, there's this crazy increase in surgical site infections between November, December, and January, right? Yes and no. So, last year, and I found a notebook yesterday with handwritten microbiology notes. Yes. So last year, there were a total of 16 surgical site infections that I only found as of yesterday. I did not know that somebody was keeping that information. I don't think the drill downs were done for each of them because it's a piece of paper that says SSI, but they weren't CMS related, so they didn't necessarily count against us. Remember, I'm doing a much, much more targeted surveillance. So a total of 16 for all of last year, and as we sit right now, not counting the PATOS, we're at 4 per procedure at time of procedure. So I might have identified an infection in February, a colon infection in February, but the actual surgery happened in January. So this is where it's attributing back to the time of procedure. Okay? So as we sit for January, our infection rate, we had 3 surgical site infections with this. So the infections, running Dan. The infections, these were identified later on, but the procedures took place in January. Of a total 904 procedures performed in January, which gives us an infection rate of 0.3319 per 100 cases. You always want to stay below 2 per 100 cases. So that's not bad. I want you guys to know, even though this is like the forefront of our minds and this is what we're focusing on for education, this is not as bad as it seems. But that doesn't mean we don't still need to work on it. So to give you an idea, let's see.
Do you have December there?
Oh boy, don't I. So of the 7, well there were 7, but I have one held out because of PATOS. I asterisked them when they have PATOS. So there were 7, but of the 6 identified, 793 procedures gives us a rate of 0.7566 per 100 cases. And I standardize this per cases because I don't want your caseload to count against you. If we only have 300 procedures, that's why we standardize it. So all of these are the number of surgical site infections divided by the total number of procedures multiplied by 100 cases, and you get your rate per 100 cases. Does that make sense? I love statistics. Oh, everybody goes, oh.
I'm getting nauseous just.
Oh no, all right, I'll put them away. I'll stop them.
Just say good rates, bad rates.
Okay.
Talk to me like I'm in 4th grade.
Good, we can do better, I promise we can do better. As it sits right now, the 2 highest risk cases, which makes sense, are our colons and our hips. That's why CMS is following these, right? So we have to be super aware of these. So like for December, for example, the rate for orthopedics was 2 SSIs per 197 total cases, which gives us a rate of 1.015 per 100 cases. That's like 4 times where we are right now for total for January, right?
How does that compare with the national average?
I will try to look, but you know how hard it is to get any hospital to give up their numbers. It's very, very difficult. I'm happy to ask around. I'll probably have more luck within my own local APEC chapter, the Associations of Professionals in Infection Control and Epidemiology. So all of our hospitals have IPs. We're all part of the APEC chapter, so I might have a better luck of getting local numbers as opposed to national rates. I can try to do that. I make no promises, because again, everybody guards. They're like, we're doing great. We're fine. Yeah. But you can find these numbers on Hospital Compare. Have you guys ever been onto hospitalcompare.gov? Make sure I'm not holding you up. So you can find numbers on that. They're generally 2 to 3 years behind. Just keep that in mind. So if we have any prevention efforts that are going into place, you won't see that on Hospital Compare for 2 or 3 years, the outcomes of that. All right. You guys seem really somber. You okay?
Were fractures on our, like fracture dips?
No, there was no mention, only if you had a protruding bone or something to that effect, but not just fractured, no, there's nothing.
Doesn't that
It'd
change
still
an
be,
old fracture?
there-
Seems like it used to change.
you're right about an old fracture, there was mention of
We
that.
get these fractured hips
Do you
in
know
here, they
off
shouldn't
the
be
top of your head?
clean.
So I count traumas. Trauma counts for me.
Yeah.
So if I have the sweet old lady that fell on the sidewalk, shattered her hip, that's trauma case.
Right.
So that's statistically adjusted for us, in our favor, because that has the potential to be contaminated as it is.
But are we changing it, is what I'm saying?
Oh, in your wound class?
It still would be clean.
Yeah, unless,
It's no, yeah?
Well,
An
if
open
it were-
fracture.
yeah,
is
an open
different.
fracture, like if you have
Yeah.
spillage, then yeah,
Yeah.
I mean, absolutely. If you have an open fracture.
Right.
Like
But I
if you
thought the
came in,
close was
if
different.
somebody stuck their hand in a snow blower and just kind of broke their fingers,
Oh, okay. I
it's
was expecting
one
it to be
thing.
gone.
But if they got their hand all sorts of gnarly,
That's what I was thinking.
then it's different, because now you've got an open
Right.
wound versus just like a fracture. So it's only changes wound class if it's open when it comes to that type of stuff.
Yeah, like a gunshot wound. It's not necessarily a dirty or infected, it's a clean contaminated. Yeah.
And so, like, say if you're just doing a closed reduction of a wrist or something, that would be no wound.
Right, no
So it'd be
wound.
zero.
No,
No-
no
no classic
cut.
wound.
Yep. Yep, yep. Yeah, ORIFs are the only thing that I tend to ever look at for drill downs.
An open fracture filled with dirt. Is it a 3?
That's a,
Fresh open
Fresh.
is 3.
yeah, that's a dirty case. Clean contaminated. And then we have the opportunity to irrigate. That's a good one. Is it on your cheat sheet?
I'm gonna look on
Yeah,
that,
it's
that
on
one
the-
where I
on
had,
the decision tree.
It
Yeah.
is?
Well,
Okay.
I don't know if it was that
I was gonna say, I'll call NHSN and be like,
exactly.
here's the
but, like,
scenario.
To walk you through it, because I just remember when I worked at Ellis, that situation happened, and it was a lot of scatter, like, what is that wound class? Because,
It's definitely contaminated,
right,
but I don't know if it's dirty.
right.
Because dirty traditionally indicates that there is some sort of gross contamination, bowel spillage, or.
Well, technically it's dirty, because there's dirt. so it's
Right, no,
dirty.
theoretically, it is, it's wicked dirty. Yes, absolutely, I agree. But
As an
I
advocate,
think it's
it is dirty.
contaminated, really. Because there's no active white count there, there's no
Right.
active histamine action there, there's no.
I think it would have to be older than 10 days to be a 4.
Oh, timeline too.
This is greater than 4 to 6 hours.
I don't know, we have one chart that says old wounds as in older than 10 days.
Okay, so let's,
It's always an interesting topic.
yeah, let's update the charts. Let's make sure we have the most, well, you just barely did this one.
yes.
Okay, so this one will be the most updated data. Because my requirements, my NHSN, the definitions literally change year to year. literary. Speaking of which, New York State has put together a proposal to also report spinal cases, any spinal cases into CMS. That came out yesterday, that proposal. And if they don't get a really good reason not to, that will be part of our CMS required reporting as well. I'm thinking about those Landys. Alright. Do you guys have any questions, any concerns? Do you guys feel empowered to speak up if you need to? You do? Okay, good. I know you guys are a rugged group. You've gotta be. If you're working in an OR, you're not a mouse in a corner, no. Okay.
Hillary's gonna be coming into the ORs to observe some of our cases, so this was also an opportunity for us to introduce her to,
Not to critique
all
your
of you.
practice.
No, I'm not gonna say anything.
It's not like that.
No.
She just wants to get a feel for our flow up here.
Absolutely, yeah. I would love to come in and view some cases. If for nothing else, I mean, honestly, I doubt that I'll be in for like a 7-hour case. I don't know if I can stand in the corner that long, because I'll try really hard not to like come in and out of the room, because I don't want to be that risk factor. But yes, I would love to come in and observe some cases and just get a feel for the flow here, see what we're doing, make sure that we are up to snuff, and if we have any areas of opportunity, you guys will probably identify them before I will. But yeah, I would love to come in, and it's not that I'm viewing anybody. I don't even want to know your names while I'm in there. The point is the process.
Well, that's part of our time on, so.
His names? All right, so I'm gonna find out. But it's always a process issue, it's never a people issue. Like I said, it takes a village to have any sort of infection.
This is a hugely engaged group.
Obviously. I've never, I harassed him in the elevator yesterday. I was like, I've never come across this. This is so amazing, so impressive, and it's so encouraging that not only are you willing to sit here, but that you're engaged and you have questions, and this is awesome. This is very, very awesome. This is not what I'm accustomed to in my previous facilities.